Hi everyone, today we're going to talk about the GI system. So one of the most important things that you're going to learn is I'm just going to tell you, when I started, I was a GI nurse, and one of the things I learned is that the GI system involves a lot of things. It involves from the mouth down to the anus, right? Anything in that area, pretty much your liver, your pancreas, your stomach, your small intestine, your large intestine. And so what we're going to look at is what to assess for these things. But first of all, before I go there, I want to show you a picture, and I'm going to see if I can shrink it up a little bit so that you can still see this. And it's really important to understand what this whole GI system is, what you're looking at, because when you get into the diseases, you're going to need to kind of have an idea of where you're looking. Okay, so I'm going to kind of try to show you, this is where the esophagus is, and if you'll kind of look, it goes down into the stomach area, so it kind of goes behind the lobe of the liver. This is the liver. If you'll see right here, look how nice and big the liver is, one of the biggest organs, and it does produce a lot of heat. If you lift the liver up, underneath this right here, let me zoom in, you're going to see a gallbladder. And if you'll notice that a lot of things, and you can't see down here, but this is the common bile duct, and this common bile duct goes in behind and it attaches into this duodenal area. Along with, you can't see the pancreas here, but it's this nice little yellow area. This also attaches into the duodenal area um, behind this duodenum. You can't see it here. This is called the common bile duct, and that's going to be important. You're going to need to know that the pancreas and the gallbladder actually merge into one common bile duct, okay? If you notice, you got a lot of vessels here, but one of the things that might be important here is how the small intestine, you're going to look at the stomach, and some of the things you're going to see in the stomach might be a peptic ulcer, right? So those are some things you're going to study for this exam, and we'll talk about that when we get to that portion. But then you're going to come out of the stomach, and the very first part of this small intestine is called the duodenum. And this, believe it or not, I didn't know this until I was a GI nurse myself, but this is where 90% of your iron is absorbed into your body. So if you have anemia, this is probably not for the test, but this is just for your information. They'll scope you, they'll go down into the esophagus, they'll look into your stomach, this is with an EGD, and then they'll peek into this first part of the small intestine and look at the common bile duct, which you don't see here. And the reason why they're looking in here at this duodenal area is to see if there's any ulcers. And you're gonna see that you've got to tell the difference between a peptic ulcer and a duodenal ulcer. There's differences in the way they present, but there's an important thing here, because if they are anemic, we could go, oh, look, they have a duodenal ulcer, and maybe that's the reason that they're iron deficient. When you get down a little further here, you've got the duodenum. It kind of curves around. And then what you're not seeing here is there should be a lot of small intestine in here. Now, a lot of people don't realize that the small intestine is also called the ileum. Oh, look, the duodenum, they show it over here, but it should be folded up into here. So remember, your small intestine, if they say ileum, that's the small intestine. And usually inside of the small intestine or the ileum, the stool is very liquidy. It has to be, in order for your body to absorb the nutrients from your food. When the ileum actually starts connecting into the colon, there's a little portion right here where there's that connection, and that's called the ileocecal valve. And I'll zoom up here so that you can see this. This is the little ileocecal valve. They also do look at that when they do a colonoscopy. Now, a lot of times people don't understand what happens when they do a colonoscopy. You only look at the colon, this large part right here. You don't go into the small intestine with a colonoscopy. If you have to look at the small intestine, you would have to swallow a camera and it would have to work its way through that small intestine. But when you do a colonoscopy, remember you're going to have to be completely cleaned out in order to visualize the colon. And here's something that's important is that the colon's not used to having no stool. It's used to having stool all the time. So when you clean this colon out, obviously it's going to be uncomfortable. It's going to be really wavy. It's looking for the stool that should be there. And so what they usually do when they do a colonoscopy is they will look inside. This is the sigmoid area. So if they have to do a sigmoidoscopy, they're just going to look in this area right here. They will go up to the transverse colon here, and they'll look down this ascending colon, and they'll peek into the ileocecal valve just to check. Vitamin B is actually pushed into the body right here at the ileocecal valve. And so if someone has pernicious anemia where they can't, or they're not absorbing their B12, they're going to look at this area right here to say, oh, okay, this could be a problem. This could be the problem. Now, one of the things I want to mention that you may not know is when the small intestine connects in here, actually, this is called the ascending colon, okay? It's because it's the way that the food or the stool is moving through the body. So this is the ascending colon, then you've got the transverse colon, then you've got the descending colon, okay? And then, of course, you've got the rectum, and then you've got the anus here. So this is really important when we're looking at the GI system also. We have to know that there are these superior mesenteric arteries and veins that are actually feeding the colon and all of the intestines and all, that organ right there. And that's very important. And the reason why is sometimes you can get superior mesenteric artery syndrome. You can have all sorts of different problems here. I remember there was one young girl when we scoped her, she was saying she was having abdominal pain. And what happened is we put the little scope in, and immediately the doctor could see that some of the colon was starting to die because it wasn't getting enough blood flow. It wasn't getting enough fluid. And come to find out, she was a runner and she wasn't hydrating herself enough. So here's a little, FYI to you and your patients, get plenty of fluid. All organs in the body need fluid, and we don't want the colon to get dehydrated because it also has a blood supply, right? We don't often think of that. But when we look over here, we're going to look at the GI tract and we're going to say, okay, what are some things we would assess, right? Number one, we're going to look at their health history, right? Make sure what's going on health-wise. We also are going to look at what kind of pain, abdominal pain, like when did it start, what relieves it, is there a certain type of pain, is it sharp, is it what kind, right? And what foods do they eat? Those are all things we're going to ask. Dyspepsia is indigestion. A lot of times in the GI world, you'll see people have a lot of indigestion or they'll have GERD, which we'll talk about. And then some foods, some people suffer from severe gas and bloating. It just depends on the person. We need to have gas has to move through the body. When we eat, we get air that sticks into our GI system, and so we have to move it out, and that's an important part of the GI tract. So cabbage can cause gas if a person eats a lot of that. Broccoli also can cause gas and bloating, and they take a little longer to digest. So just be aware that some foods, if someone has a problem with too much gassiness, then they may, be eating something that's causing it. So we're going to ask them about their nausea. We're going to ask them, are they vomiting? Are they having coffee ground emesis? That could mean a upper GI bleed. Are they having diarrhea? And this would be like black tarry stools. Now, one thing that's really important to note here is if you are having coffee ground emesis, which you're vomiting, it looks like a dark coffee ground, then that would be an upper GI bleed, okay, stomach up. If we have black tarry stools, then we are looking for a lower GI bleed, or excuse me, an upper GI bleed there. But if we have bright red blood, then we are going to have a lower GI bleed. So the bleeding, the type of blood, what it looks like is a really important thing. Are they having constipation? Are they having fecal incontinence where they, you know, that the rectum's not shutting correctly? Jaundice. Remember, I told you the liver is a huge part of the GI system. And so we're going to look at the liver and we're going to look at jaundice. And do they have any, or have they had any previous GI disease? And have they had bariatric surgery? These are some of the facts that your instructor will, want you to just kind of go around in your mind. Now, one of the big things when you work in a GI field is stool characteristics. What does the stool look like? It's almost like it tells you a little bit about what's going on in the body. So medications obviously can change the color of stool, and iron can change the stool to a dark green, and sometimes laxatives can change it to yellow. Foods, and she may want you to know this, foods, green veggies obviously can make it green or mustardy looking. Meat protein could be dark brown. Spinach could make it green. Carrots, beets, red gelatin can make it red. Now, the reason why I say that one is because we had a patient who came in and she says, I'm having rectal bleeding. She says there's blood in the stool. And come to find out, she was a beet eater. She started eating a lot of beets to get healthy, and it made her stool red. It made it look like there was some blood in it. Cocoa, dark red or brown, and then barium. If they have to do a barium enema or barium swallow, their stool will look like a white clay colored. And so these are just things that if somebody called you and said, my stool looks this, you have to ask questions, did you just have a barium enema? Did you just, what kind of foods are you eating? The normal color of stool is light brown to dark brown. That's normal. And let's see what's abnormal here. Abnormal would be dark tarry black. That's called melena. Remember that. If it's dark, that means it's had to take a while to work its way through the GI system, and so that would be an upper GI bleed. If there's bright red or streaks of blood, it could be a lower GI bleed. Usually the streaks of blood in stool usually means a hemorrhoid of some kind. It's kind of, the hemorrhoid is right there, and we'll talk about hemorrhoids when we get to that portion. There's some other abnormalities that you need to be aware of that, are in the stool. Bulky stools, greasy, foamy stools that are foul in odor, and may or may not float. See, there's just so many different things to look at. Light gray or clay colored stool caused by a decrease or absence of conjugated bilirubin. So like if they have clay colored stool and they didn't have a barium enema, something could be wrong with the bilirubin production. Stool with mucus threads or pus that may be visible on gross inspection of the stool. That just means visual. That could be something there. Small, dry, rock-hard masses, occasionally streaked with blood. Could be they're not getting enough fiber. Loose, watery stool that may or may not be streaked with blood. So, do you have to memorize all that? No, but I think you do need to know what is normal, what is not normal, and what foods could change the color of your stool. I do also think you need to know dark tarry black stool, melena, could be an upper GI bleed. And then bright red bleeding from the rectum, it could be a lower GI bleed. That's how we look at it, okay? So let's do a social history on the patient. What do they normally eat? Daily food, right? Alcohol, tobacco. We're going to ask them about that. We're going to teach patients to avoid certain foods, and you'll see, according to the disease, we're going to tell them to avoid certain foods. And so pay attention to those, like caffeine, coffee, chocolate, even decaf, coffee, tea, and soda, we should avoid if we're having a GI problem. Actually, smoking speeds up the GI tract. So look, increased ulcer bleeds. It can affect the GI tract more than people think. Alcohol, spicy foods, highly seasoned foods, fatty foods take longer to digest. NSAIDs increase bleeding. Now, a lot of people, you probably already know this, but NSAIDs, we usually tell the patient, hold your NSAIDs before procedure because it can increase risk of bleeding. But A lot of students don't know that NSAIDs contain a little bit of aspirin in them. This is exactly why we have them hold this, because aspirin can also cause a GI bleed. So NSAIDs, if somebody is having a peptic ulcer, is probably not a good idea, right? Peppermint, actually peppermint can cause a lot of GERD, and it can increase the acid content in the stomach, and then eating late at night. So we're going to look at all these as we go through the diseases. So just be aware, this is just like a little introduction to you. Physical assessment. So if you get a patient in, we got to look at what's going on in their oral cavity, right? Because remember, I said the GI tract starts from the mouth and goes all the way down through the anus. Sores, like their teeth, their breath. I mean, if they have dentures, that it could cause a GI problem, because maybe they're not chewing correctly, or, maybe we just want to look and see what's going on. Are the lips symmetrical, moist in color? What do their gums look like? What's their tongue look like? What's their abdomen look like? Remember, when you're looking at the abdomen, isn't it inspect first? You always just kind of look, and then auscultate, percuss, and then palpate is last. So we want to remember that as we go through this. All right, let's just look. We're gonna put this one on this same video. We're gonna look at some GI diagnostics. Now, here's the thing. If you have a patient, and I want you to be the GI nurse on this test. So if you have a patient who comes into the office, at a GI office, and they say, oh, I feel like this is going on with me, it doesn't matter, whatever. We used to have a list of labs that we know the doctor's going to order, so we would just check off or circle these labs and give them the lab sheet so that they would go and get these labs done, and then the doctor would sign it. And so there's some common ones here. A complete blood count is going to tell us a lot, obviously, if there's an infection or something. And then you can get a complete metabolic panel, which is going to it's going to get a little more detailed there. It's just like a CBC with a little more detail in there. And we definitely want to look at a coagulation panel. Now, here's the thing. Remember, when you're in the GI world, the liver is a big part of GI. And the liver is the one that produces a lot of our coagulation factors. So we want to look at the coagulation panel. We also want to look at triglycerides, what's going on with that. And some people can have what's called fatty liver. So we want to know, what is their cholesterol doing. Liver function, liver needs to work. This is interesting. In order for you to have TPN, it needs to work. The pancreas actually will produce some enzymes, and we got to look and see whether those enzymes doing, if there's an abundance or not enough of them, it could be a problem with the pancreas, right? Now, this one is called a CEA. And anytime you see this lab, it's a carcinoembryonic antigen, then, and if it's high, that means there's cancer somewhere in the body. And a lot of times, if the doctor suspects it, he'll run a CEA on the patient. You'll look at, they'll probably do some types of stool test. They can look for ova, parasites, different things. And then the breath test is really good at detecting H. pylori. So those are just some, diagnostics that you need to be aware of. And as we go through the diseases, you're going to see some of these pop back up, so pay attention. Abdominal ultrasound is really non-invasive, no radiation, no side effects. Sometimes if they suspect gallstones or something like that, they'll just go and say, hey, let's send them for an abdominal ultrasound. So if somebody was going for an ultrasound, remember, you're the nurse, you're going to educate them. We're just going to say, hey, you just need to fast for 8 to 12 hours prior, be NPO, after midnight, do a fat-free meal the night prior, no fast food, right? And then barium studies after the ultrasound. If you were going to do an ultrasound with it and then have a barium study, you would always do the ultrasound first, because the barium is going to make everything not visible on the ultrasound. So there you go. Make sure you know how to educate someone if they're having an abdominal ultrasound. Now, let's say, I ordered a lot of these upper GI studies, and what they can look at is they are sometimes usually have the patient do a barium swallow or barium drink, and or die, depends on what what they're doing. Remember, it's hard on the kidneys. Renal patients will need some, especially if it's the contrast. Renal patients will need to add acetylcysteine, and it says before, but I've seen it where it's before, during, and after to help remove the contrast out of the body. Okay, detects or excludes anatomic or functional disorders. That's what it's doing when you're looking at the barium. It shows a nice outline of what you're trying to see. And then, so what would we teach the patient? Clear liquids the night before, be NPO after midnight. They probably are going to have to clean their colon. And if you see polyethylene glycol or Go Lightly is the lovely cleansing agent that they give to the patient. And I'll explain that, how it works and everything in a future video. Avoid gum, smoking, and mints. It stimulates the GI tract. And then barium is commonly used after testing increased fluids. Make sure you know that anytime we do anything in the colon, whether it's an EGD, whether it's barium, whatever, we got to worry about any type of perforation or rupture. And tell the patient the stool will be clay color for a while, maybe for a day, and that would be kind of normal till we get rid of that barium, and just make sure they know that. Now that was the upper GI, okay? And now we're going to look at the lower tract, or the lower GI. Visualization of the lower GI tract is going to take barium that's inserted rectally. So what are we going to do here? We're going to do a low residue diet 1 to 2 days prior to the test. Limit high fiber foods like whole grains, cereals, nuts, seeds, raw, dry fruit, or vegetables, because we're going to try to get the colon clean, right? And then it says be NPO after midnight. And then they're going to do the cleansing bowel treatment. I'm going to point something out. Polyethylene glycol and Go Lightly are the same medication. That's the same. And I always used to joke with patients, it says Go Lightly on here, but that doesn't mean you're going to go lightly. You need to be by the bathroom. Post-test, you're going to increase your fluids just to get rid of that barium, and then monitor your bowel movements, right? So did you know that you can use barium to go upper GI or barium to go lower GI, but you're going to do it in different ways. This one's going to be inserted rectally, and this is probably going to be by a drink. Okay, yeah, a very yummy drink. So we could do a CT. A CT shows more detail. We also are going to run dye in the patient, watch for allergies, watch for the kidneys. An MRI, you guys know, is the magnetic resonating image, and it's noisy. You go into a little tunnel. People feel claustrophobic, and it takes about 60 to 90 minutes. Remember, no metal on the patient, because this is a magnet, right? Colonoscopy. I talked a little bit earlier about a colonoscopy. Remember, it just visualizes the large intestine, or the colon. The whole large intestine is called the colon. And so usually they recommend every 5 to 10 years for a colonoscopy, unless there's a problem, and then they might do it, sooner, depending on. But what it allows them to do is go in and visualize the colon and what they're looking for. If some people don't even know what are they looking for. They're looking for little growths called polyps. And these little polyps, some people are polyp producers. In fact, there was one family that was a polyp family. I call them the polyp family. And they all had to have their colon removed. The whole thing, the whole colon removed, because the colon was packed full of polyps. And I remember they cut it open and laid it out, and it was just amazing. I wish I had a picture that I could show you. But this is going to visualize the inside of the colon and let them see if they can detect any of these polyp growths. Some people make 1 or 2 polyps, and but they're very slow growing. But they can turn into cancer. So that is why we do a colonoscopy, to remove those polyps, right? So when you do a colonoscopy, we're going to worry about positioning the patient, and They love to use propofol, which is the sedation for a colonoscopy. Uh, but here's the thing with a colonoscopy. Whenever we, and I said this earlier, whenever we stick a something inside of the colon or in the esophagus, either way, we worry about perforation. That's going to be big, and you worry about a rigid board-like abdomen. That is a sign that you have some type of perforation. We're looking at level of consciousness, vital signs, distension, pain. Vital signs will look shocky, which would look like, the blood pressure will drop and the heart rate will go up. And look, it says get the polyp now, not later. So this is why we encourage patients to do colonoscopies, is to remove that polyp while it's not dangerous. And then don't wait until it's something more serious. We are going to have to clean the bowel with a colonoscopy. You're going to have that Go Lightly treatment. The boards like to ask about polyethylene glycol or Go Lightly, but there's many more medications that patients can take to clean themselves out. Maybe that is not quite as hard to take. Go Lightly is very hard for people to drink, but we're going to do that. We'll make sure the bowel is clean. They're going to do a liquid diet the day before, and we got to get a consent. Don't forget about that. Colonoscopy needs a consent. Now, this is to look at the colon only. This is not going to see the small intestine. This is not going to see the esophagus. You can't go from the rectum up to the mouth. You can't do that. But here is where we can look from the mouth into the stomach and into that first part of that small intestine, which is the duodenum. This is called an esophageal gastroduodenomy. And you can see why they abbreviate it EGD. It's a lot easier to say. We can visualize what's going on in the esophagus and the stomach, that duodenum. They can do a little biopsy if they have to. It takes about 30 minutes. It's not a bad procedure because you're on propofol and you're sound asleep. And so we're going to need to get a consent. The patient will be asleep, but it is an invasive procedure. For this procedure, it's a little different. You don't have to clean your bowel. You just are NPO for 8 hours. And then after the procedure, because we went down the throat, we want to make sure we check for a gag reflex. And you're not going to send the patient home till they can swallow. We might have them cough, and that will give us a sign maybe that they have their gag reflex back. We're going to look at a level of consciousness, no driving, probably for both of these, no driving. A sore throat after is kind of normal. What they'll do usually during or before the procedure is they'll spray a little lidocaine in your mouth to kind of numb as they, take the little tube and go down in there. But you can use cough drops. You can have some cold drinks after. Usually after any of these procedures, we'll sit them up and we'll give them a little soda. And the soda is cool and the carbonation. There is a rupture risk anytime a tube goes down into any body cavity. And it says during this procedure we can fix a bleed, and they're talking about esophageal varices. We can fix those, and we'll get into that. So this is going to be just a beginning for us to know, hey, what is the GI system? What things are we going to look at? What do we need to ask the patient? And I hope this is helpful because we'll get into the detail now on the next one. All right. And hopefully this will help you have an idea, and which I wish, and I'm just going to say on this test, you be the GI nurse. And this is just like, hey, we are talking together. You just got a job with me and I'm showing you what you need to know. Okay. But this is for a test. So we'll talk to you later.